give a presentation in this room. It'll be probably partial amount of the time. We'll also do a bit of a fireside chat when JJ is done with his prepared remarks. In the back, we also have CFO Dan Spiegelman and Tracy McCarty of Investor Relations. JJ.
Thank you, Phil. Good morning, everybody. Pleasure to be here. This presentation will contain forward-looking statements, so please refer to our SEC filings. So, BioMarin is a 21-year-old company. We now have 7 approved products on the market. We anticipate that they will be generating around $2 billion of revenues next year. And we, in addition to the products on the market, we have a significant pipeline of products: vosoritide for achondroplasia, Valrox for hemophilia A gene therapy, trolicidinase alpha for MPS IIIB. We anticipate filing an IND for our second gene therapy product, PKU gene therapy, BMN 307. And we anticipate making decisions on filing an IND for BMN 290 for Friedreich's ataxia in the second quarter of this year. Actually, we were talking about the history of the company and realized that actually most of our products were developed against a wall of worries, and most of them experts were saying they should never be approved. So we are generating now $1.7 billion of revenues with products that should have never been approved. And we anticipate continuing to do the same with Valrox being the next candidate. So we're going to generate about, say, around $1.7 billion this year. We do $1.5 billion last year, 15% growth, again, $2 billion in 2020. After that, assuming Valrox and or vosoritide are approved, we should see a significant acceleration in the growth of the revenues here. So we are in pretty good shape. I'm going to focus on my presentation on Valrox, and then during the Q&A we can talk about the other products. So before I get to Valrox, 2 other products that are of interest, Palynziq and vosoritide. So when we start with Palynziq, we got approval in the U.S. In Q2 of last year. We launched in Q3 in the U.S. The launch is doing very well, actually exceeding our expectations. Specifically, there were some concerns before we launched that, what would be the allergic reactions management outside of a clinical trial? And I would say, well, we have now treated close to 400 patients in the U.S. and it looks like this is not a major issue. We have seen some severe allergic reactions as anticipated, but the patients manage them well, and most of them actually are back on Palynziq treatment today. The good news recently is that we got a positive CHMP opinion at the beginning of this month, which means the product is very likely to be approved in the second quarter of this year. And also we got a pretty nice potential labeling, better labeling than in the U.S. potentially, with patients eligible for Palynziq treatment when they are over 16 years of age instead of 18 in the U.S. We got a 60 milligram vial dose approved, and also a mention of neurocognitive benefit likely in our labeling. So the revenues this year, first full year in the U.S., are anticipated to be $70 to $100 million. Obviously, the European approval will really have an impact in terms of revenues next year more than this year. And then moving to vosoritide, we enrolled the last patient in our pivotal phase 3 trial in November of last year. So we should have very top-line results at the very end of this year or very early next year. And we're also treating now, all the patients in the pivotal trial are 5 years or older. We are treating also, we're doing a study, what we call the infant and toddler study, which has 3 cohorts. We are done treating the first cohort of patients that are between 24 and 60 months of age. We just started the cohort 2, treating patients from 6 months to 24 months of age. And likely next year we'll do the cohort 3, which is patients under 6 months of age. So because the disease impacts the patients before birth, so the earlier we treat them, the better. We hope to be able to use this data as supportive data for the filing of vosoritide. So back to Valrox. So we announced recently that the enrollment for the subgroup of patients that we will need for accelerated filing has been done at the beginning of this year, completed. We also announced that we've done the 3rd PPQ lot, manufacturing lot. Will be done with the manufacturing of that lot at the end of this quarter. That means on the CMC front, we'll be in a position to file for accelerated filing at the beginning of Q4 of this year. Then, of course, we need the clinical data, which we are generating right now. And also, we have enrolled already over 100 patients in the pivotal GENERATE-1 study, which is needed for food approval. We are shooting for 130 patients for food approval with annualized bleeding rate as a primary endpoint. So we are positioned and on track to be able to make a decision on accelerated approval filing in the second half of this year. So where do we stand in terms of the interactions with the regulatory authorities and commercial preparation? So we're going to look at different components here. The accelerated filing potentially this year, end of this year, early next year. Food approval likely at the end of next year. We have regular agency interactions with the U.S. and the European authorities because we have breakthrough designation in the U.S., for instance. We are doing significant engagements with payers, doing pricing research, looking at different potential clinical outcomes and the reactions of payers to those outcomes. And we are already preparing. We have a hematology division now, commercial division within BioMarin. We're hiring employees and we're getting ready for the launch, which if we do file early next year, end of this year for accelerated approval, we could be on the market in Q3 of next year. So let's now focus on accelerated filing. What do we need for that and what the activities are needed? So the basis of accelerated filing will be a sub-segment of the full phase 3 trial, the first few patients enrolled in the study basically. And we have agreement already on the FDA as to what is the critical threshold of factor VIII activities we need within the first 12 months to be able to file for accelerated approval. It's based on a fraction of patients that have, within the first 12 months, transgene factor VIII expression above 40 international units per deciliters or 40% of normal. And I'll get back to that later. Also, they want, of course, our 3 manufacturing lots to have been completed, and we are on track to do that. Less important, but there, in case if there was a dramatic drop in efficacy of the product in terms of a lot of breakthrough bleeding in the phase 2 patients, the phase 2 mid-year trial update in terms of 3-year data is kind of there, but it's not a critical endpoint for filing here. It's a phase 3 data, the critical endpoint. And also we had to demonstrate to the FDA that whatever factor VIII levels we see with the chromogenic assay are correlated with bleeding control or bleeding activities, and we believe we've done that, so this will be the assay that will be used to measure transgene factor VIII activity within the first 6 to 12 months. So let's go back to what we showed for the phase 2 data in the first year, because this is what's important here in terms of factor VIII levels. This is the slide that shows transgene factor VIII expression levels using the chromogenic assay in the first year after treatment with gene therapy with a high dose, the 60 to the 13, which is going to be the basis of the filing. As you see here, the mean and the median are both about 50 to 60% at year 1, and basically 6 out of the 7 patients that we treated in the phase 2 trial were above 40% factor VIII expression with a chromogenic assay at year 1. Needless to say that if we have similar results with the first phase 3 patients, we should be able to file for accelerated approval, but we need to have the data. Also, reminder of the phase 2 results at year 1 and year 2, which is the data we presented in May, June of last year. So these are the patients that were on the high dose, 60 to the 13th. These are severe hemophilia patients that were on prophylactic factor VIII injections 2 to 3 times a week in the previous year. On the left, you see their pre-infusion annualized bleeding rate, which is a clinical outcome here. These patients had bleedings at ABRs above 16 bleedings episodes per year before treatment. After treatment with Valrox, their bleeding rates went to medium 0 at 1 year and 0.9 average. And at 2 years, 0 also median, 0.5 bleeding episodes at year 2. So one has to understand that you need to report all bleeding episodes in your studies, including bleeding episodes that might not really be related to hemophilia and that are not target joints or spontaneous bleeds. This is why they are bleeding. So just want to highlight here at the bottom of the slide here that 6 out of 7 patients were free of any bleeding episodes, whether it was spontaneous or traumatic. All the patients are off prophylaxis. After year 2, none of the patients were on prophylactic factor VIII while they were receiving over 100 injections per year before treatment. And 100% of the patients are at the resolution of target joints bleeds, which is an important measurement in hemophilia. This is the data we have at year 2. So, importantly also, we measured quality of life with a validated quality of life scale in hemophilia that has actually measurement of 6 domains that you can see on the right of the slide here. And interestingly enough, you see that actually the quality of life of these patients, the light blue is the high dose. The quality of life of these patients improved even further at year 2 as compared to year 1. The gray line here on the slide is actually what's considered clinically significant. You can see that with the improvement in quality of life is very significant at year 1 and year 2 with the high dose Valrox. So why is it that annualized bleeding rate, factor VIII use, and quality of life are key measures of success here? And we're going to look at that whether the stakeholders are regulatory authorities, patients, or payers. So for regulatory authorities, in terms of food approval, annualized bleeding rate is definitely the endpoint, along with factor VIII use, of course, but they are linked to each other, which is a measure of clinical outcome for food approval. The quality of life is actually also important for regulatory authorities. Just want to remind you that, again, we showed improvement in 6 of the quality of life domains here as compared to a recently approved product that only had so far communicated about 1 of the domains showing any improvement. So the factor VIII activity levels are really important for accelerated filing. Beyond accelerated filing, they're not important because that will be the basis of accelerated filing. And the FDA, as I said, told us that they want a significant number of patients that have, within 6 to 12 months, factor VIII expression levels above 40%. And the reason is that they told us if you want to get this product approved with a small number of patients, what will be the case here, we need to set the bar pretty high here. And I would say there is no other factor VIII gene therapy product in development that has ever reached that level. This is chromogenic, not one stage. So patients, obviously, ABRs and factor VIII use is really super important for them. This is the clinical outcome. Quality of life, also very important. Factor VIII activity levels are not really relevant for day-to-day disease management. They don't measure the factor VIII very often. And the payers really care mainly about factor VIII use because this is what they pay for. This is what, they cost them money related to annualized bleeding rate, so they really care about those two. Quality of life to a certain extent, but the factor VIII levels long-term are not used to determine the value proposition. So the big question we're getting is, well, how long is it going to last? And is it going to be 4 years, 3 years, 5 years, 10 years? Nobody knows. So the only proxy for how long it's going to last is animal data. We have dog data with hemophilia A that were treated with gene therapy factor VIII, and their bleeding control lasted the entire life of the dog for around 10 years. We have non-human primates data that show also long-term durability. There are now over 1,000 patients that have been treated with AAV gene therapy in different indications that have shown that the sustainability of the expression of the transgene that's being treated. But I would say the closest proxy for how long it's going to last is actually data with factor IX in hemophilia B. This data was presented last December at ASH by Dr. Natwani. Actually, Dr. Natwani works at UCL in the UK, and we in-licensed some technology from him to develop Valrox. And this is the data that he's shown. He's treated now hemophilia B patients with factor IX gene therapy 6 to 8 years ago. So he did that study in 10 patients on the right here, on the left side of the screen here. 2 patients at low dose, 2 patients at mid dose, 6 patients at high dose. So he has 8 years of data for the low dose and mid dose patients, 6 years for the high dose because he treated the high dose patients later. You can see on this slide, this is with chromogenic assay. You see that the expression, even in the high dose in red here, never went above 7%, and is around 4.5% after 6 years. And with that kind of expression level, he was able to actually show a dramatic impact on bleeding control. If you go to the far right of the slide here, this is the high dose patients on the right. They went from an annualized bleeding rate of close to 22 bleedings per year to 2.3 bleedings per year after 6 years of treatment, and only 5% factor IX expression. So this is what's available in terms of data. Ourselves, we do not know, nobody actually knows what is the minimum amount of transgene factor VIII expression that you need to have bleeding control. We are the first company in the world to actually do that study. This is our phase 3 trial that will show a relationship between factor VIII levels over 1 year, 2 years, 3 years. We're going to continue treating the patients beyond the current study in long-term extension, and the control of factor VIII, the control of bleedings. But this is the data that's available. So where I stand today, if I had to bet, I would say it's going to last at least 8 to 10 years, but nobody knows. Maybe 15. So let's move on to full approval. Again, so we're going to potentially file for accelerated approval, but we are going to continue the study anyway for full approval. We have already enrolled over 100 patients in the baseline trial, because what we do, we enroll the patients in the study, we follow them for at least 6 months to have a baseline bleeding rates level and factor VIII consumptions, and then we enroll them into the trial itself in terms of treatment with Valrox. So we have enrolled over 100 of the 130 that are planned to be enrolled, so we're pretty confident we will be done treating all the patients by Q3 of this year. And interestingly enough, also, I think there was this whole debate in the past, maybe high factor VIII levels are not that exciting for patients. They want lower factor VIII levels because they're worried about side effects, whatever. Well, we have a real-life example of what's going on here. We offer the patients both doses, the high dose, the 6e13, and the low dose, 4e13. And 95% of the patients choose the high dose. So they want, at least initially, some, pretty high factor VIII level expression. So this is a real-life example of patient demand here. The primary endpoints of the 52-week study are annualized bleeding rates and factor VIII usage. We're doing the study, true international study in 13 countries. Again, we expect enrollment completion in Q3. So we have had multiple interactions and continue every quarter or so to have interactions with the regulatory authorities, because we have breakthrough designation in the U.S., prime status in Europe, which is equivalent. We now have key agreements with all the authorities regarding the plans for marketing applications in the U.S. and Europe, including definition of success criteria for phase 3 study interim analysis, for accelerated approval, structure, format, and content of all the modules in the filing, CMC, non-clinical and clinical, data cuts and size of the safety database, and final results from the phase 3 to serve as confirmatory evidence of full approval. Actually, we're planning on meeting with the U.S. and regulatory and European authorities in the middle of this year, once we have the first segment or sample of the phase 3 study. So we will do an interim analysis of the phase 3 study, and we also have at the same time a 3-year update for the phase 2, and that will be the basis of our decision to potentially file for accelerated approval in the second half of this year. Let's move on to pricing and reimbursement. Despite the availability of recombinant factor VIII injections and other products, there's still a pretty high unmet need with the current standard of care. Patients still, as you saw from our own data, they still have recurrent joint bleeds, deterioration of large joints, they need repeat surgery. Some patients actually who have never had a declared bleed have the need for surgery. Burdensome weekly infusions for recombinant factor VIII. Patients limit severely their physical activity before the next injections. There are peaks and troughs in the level of factor VIII, and very high costs for lifetime therapy. With Valrox, you can potentially eliminate the bleeds, no more target joints bleeds, one-time infusion for several years, potentially lifetime, meaningful quality of life improvement, and cost offsets of millions of dollars over the lifetime of the patients. There was a recent survey done by another investment bank. Sorry to bring that up. It's very recent, so it's kind of interesting. The survey that was done, I think, with patients and hematologists, and we asked them to project, actually it was done with hematologists that treat, a lot of hemophilia A patients, and they were asked, after 1 year, 2 years, 3 years, 4 years, 5 years, how many of your severe and moderate hemophilia patients do you think, based on available data today, will have been treated with gene therapy? You see that it goes pretty high to basically 45% or so for severe patients and 25% for moderate. So that's very, very encouraging. And that's coming from hematologists. We also have done research with payers. And the payers so far just based mainly on the 2-year phase 2 data. These are their reactions. It's amazing. You can eliminate, this is a U.S. National Managed Care Organization payer. It's amazing you can eliminate bleeds and factor VIII use. I don't know what the cost of product X is, that was Valrox, but it's going to be a worthwhile equation, taking away adherence, which is observance issues, joint erosion, which is target joints, decrease, and long-term complications. You are changing the course of this disease. Findings from recent U.S. payers interviews, payers perceive the elimination of spontaneous bleed as the most important attribute for a new product. Reduction in factor VIII injection use resonates with payers as many immediately associated with potential cost offsets. Now we've done marketing research with patients ourselves based on the phase 2 2-year data. So we show them the profile of Valrox based on 2-year data. We've done research with patients, hemophilia patients in the U.S. and Europe. More than 40% of them, they view the Valrox product profile express, and they would like to be treated within 1 year of launch. Actually, if this is the way they're going to behave, actually we will not be able to actually treat the 40% of patients. We don't have that capacity. But even if it's half of that, I think that bodes well for demand here. You can read the other one. I'm going to move on for the sake of time, so a little time for questions. Just want to say we are actively preparing for the launch of this product. We're trying to establish BioMarin in hemophilia. It's a new company. We are doing a lot of gene therapy education. There is very limited understanding of gene therapy right now by many hematologists and patients, of course. And we are preparing the payers for the potential launch of this product. So just want to give you some perspective on, actually maybe go to the next slide and then go back to this one. There are around 120,000 patients with hemophilia A in what we call the BioMarin world, which excludes India and China and most of Africa. Half of them are severe hemophiliacs and 22% of them are moderate. So obviously initially the severe segment is our target. And if you narrow it down to patients over 18 years of age, patients with no pre-existing antibodies to factor VIII, you around 82-85, it's around a 35,000 patients initial target. The cost of therapy with recombinant factor VIII prophylaxis in the U.S. is between $400,000 and $700,000 a year. So let's go back to potential revenues here. How do I go back here? Maybe this way. Yes. So we have capacity today to treat 4,000 patients per year. We could go to 5,000 relatively easily by adding some equipment in the existing facility. So 2 years of recombinant factor VIII injections prophylaxis is $1.5 million a year. You can do the math. 3 years is over $2 million. So if we were able to obtain $2 million per patient at 2,000 patients per year, is $4 billion revenues. Our revenues last year were $1.5 billion. That's for perspective. But we can go all the way up to 4,000 patients. This is the potential revenue that could be generated here by this product. And finally, as some of you know, we have our own in-house manufacturing facility that we built 3 years ago. We believe it is a facility that is manufacturing gene therapy products at the largest scale in the world today. This facility supports multiple 2,000 liters reactors. It's a multi-product facility. We could do Valrox and our PKU gene therapy product there, and maybe a third one. As I said, supports 4,000 to 5,000 patients per year. So we are ready in this respect to launch the product. So thank you for your attention, and we're going to move to a Q&A here.
That was really helpful. Thanks, JJ. After our dinner last night, we put out a note, and the number one thing that we got comments on this morning was our contention that you and the management team don't know the data from that 3-year analysis of the phase 2 trial as you sit here today. Can you talk about why you don't know that data? Did we correctly interpret your comments last night? And
yes. So nobody at BioMarin, is this working?
Yeah.
Nobody within BioMarin at every level of the company knows what's happening now with the phase 2 patients, and of course what's happening with the phase 3 patients, because we have treated a significant number of them already. Why is that? Because although the phase 2 studies was initially an open label study, and we obviously knew the data until the second year, as we started the phase 3 trial, we didn't want to influence the phase 3 data by having clinicians and patients know what was going on with the phase 2 and potentially try to infer relationships between factor VIII levels and bleeding episodes. And why is that important? Because bleedings by hemophilia patients has a subjective component. They don't always know whether they have a bleeding episode, and sometimes they self-inject factor VIII, so they report a bleeding episode when it might not be documented afterwards. So to preserve the integrity of the phase 3 trials and avoid difficult discussions with the regulatory authorities, it was very important that not only the phase 3 study was blinded, but the phase 2 study was blinded. At the same time, of course, if something significant was happening in terms of bleeding episodes, whether in phase 2 patients or phase 3 patients, the data monitoring committee then would have to tell us, because we might need to change the protocol of the phase 3, increase the dose, for instance, or change, rules around use of steroids and that kind of stuff. And in that case, I would say in that case, it would probably be what's called a material event, and we probably would have to tell you.
One last question on Valrox. One person pointed out that the risk factors in your 10K, I think, changed around the language of factor levels in the trials. What gave rise to that, and how the language changed?
Actually, you looked at me more. I'm not sure what exactly you're referring to. I don't remember the wording.
Yeah, I honestly, I'm not sure.
I don't know. I think it's just the regular, risk factors that have to be updated so you don't get into trouble. But I would say that is not related whatsoever to any new information, because we don't have it.
Got it. Okay.
That's your question.
That's perfect. Moving to Palynziq, launch is underway. Have there been any surprises over the last few months in terms of safety, efficacy, or uptake?
No, again, I think if anything, the surprises have been positive in the sense that it appears, again, it's still a limited number of patients, but it appears that the severe allergic reactions are similar to what was observed under a clinical trial setting. And that actually, so we've had a few patients that have had severe reactions, but as I think I said earlier, half of them or so are back on therapy. And none of them have had major problems that were beyond what was observed in a clinical trial.
What's your most recent thinking on the peak sales potential of Palynziq?
I think this is potentially a $1 billion drug because now that the ex-US approval is around the corner, there are actually more patients in the U.S. in Europe than in the U.S. adult PKU patients. Between the U.S. and Europe adults, you're talking about 30,000 patients plus. The cost of treating these patients, these are adults, the cost of treating adult PKU patients today in the U.S. is around $200,000 per year. It's lower in Europe. But still, you can do the math. This is a $2 billion plus market.
Maybe moving to Vosoritide, we'll get the pivotal data from that program towards the end of this year. what data is necessary to drive uptake in that market?
But I think it will be confirmation of the improvement in annualized gross velocity in the phase 3 trial, similar to what was observed in the phase 2, and some indication that this improvement in annualized gross velocity results in a better final adult height, and we will have some elements of that because by the time we file or get approved, the phase 2 patients will have been treated for over 5 years or so, and some of them might be at or close to their adult height.
Perfect. With that, it looks like we're out of time. Any last comments, anything that you'd like to address?
No, I think we are very excited about both the Valrox and the vosoritide opportunity, and a lot coming this year on Valrox, and looking forward to updating you this summer.
Perfect. Thanks so much for your presentation.
Yeah, thanks.